Okay. All right, we'll get going. Morning, everybody. We're going to go over some cases today talking about disorders of collagen and elastic tissue. So that kind of is a large category, and we're going to talk really, as I look at the list here, it's not everything is going to be collagen, elastic tissue. We're talking about things that they've got some granulomatous inflammation, connective tissue diseases. So I guess I'd probably, rather than calling it collagen elastic tissue, which kind of think of maybe things like Ehlers-Danlos and stuff like that. We have a couple of those at the end, but mainly we're talking about connective tissue diseases and then a little bit about some disorders of collagen elastic tissue. So start off with this one, and we've got a, looked kind of like a biopsy that was taken in multiple different ways. They probably did a punch, and then they noticed the lesion was kind of deep, and so they kind of tried to do like an enucleation biopsy. And here we've got a granulomatous dermatitis with these histiocytes in the dermis. And we talked about palliated granulomatous dermatitis last week or a couple of weeks ago. Well, this is another one that falls into that same category. And as we talked about the things that you look for, you look to see what's in the center of the palisade. If there's fibrin, things of that nature, that makes you think of the possibility of a rheumatoid nodule. And indeed, in this case, that's exactly what was present in the center of this palisade that we see here. We got this pink material is fibrin. There may be some degenerated collagen also, but there's fibrin in the center of the palisade and rheumatoid nodule. And there's also, you can see the histiocytes are usually, some may be multinucleated, but a lot of them are just kind of epithelioid histiocytes admixed with some lymphocytes here. So this is an example of a rheumatoid nodule. And you can see these are most commonly on volar skin. And you can see this is taken from near the hand or maybe the elbow, something like that. But most of these are close to an area where the skin is really thick. And then you can see that how deep this is. Notice that we've got the papillary dermis here, the reticular dermis. This thing is really situated down in the lower part of the reticular dermis and maybe even impinging into the subcutaneous fat. So nice example. So again, the differential diagnosis of this would include subcutaneous GA. We call it subcutaneous GA when it's really in the lower reticular dermis, but basically palisade, fibrin, maybe some degenerated collagen, usually not much mucin in rheumatoid nodule. Okay, the next one, got a punch biopsy, and we have low magnification. It's got a superficial perivascular infiltrative lymphocytes. And notice that some of these look like they're hugging the area just beneath the epidermis. So when we see that, we start thinking of interface dermatitis. And when you think of lymphocytic interface dermatitis, I want you to think almost immediately like a reflex arc of the connective tissue diseases. So there's a relatively small number of things that give you a superficial perivascular interface dermatitis with lymphocytes and vacuolar alteration, lupus erythematosus, and then its histologic identical twin, dermatomyositis, which those basically can look almost identical under the microscope. So just like we think of pemphigoid and pemphigoid gestationis as being histologic identical twins, you pretty much just go ahead and think of dermatomyositis and in lupus, usually subacute lupus and acute lupus as being histologically identical almost to dermatomyositis. And it's tough to tell them apart most of the time. There are a couple of things that can kind of help you a little bit. This is dermatomyositis this time. If you biopsy a Gottron's papule of dermatomyositis, it actually, interestingly enough, shows almost no inflammation. It shows some smudging and some thickening maybe of the basal membrane zone, slight. It's not like you see with discoid LE, but there's some alteration of the DE junction that you can see in a Gottron's papule with dilated blood vessels and almost no inflammation. So surprising, you see a lot of redness and maybe that heliotrope color clinically, but when you biopsy it, there's almost no inflammation. So if you see that, you can think that that might be a Gottron's papule. But if you see something like this, you got a little bit of smudging of the DE junction, you got a little bit of sparse infiltrative lymphocytes, you got some vacuolar alteration, maybe an occasional dyskeratotic keratinocyte. Really can't tell this from lupus. And mucin is not a diagnostic criterion for connective tissue disease. You can get lupus with zero mucin or lupus with a lot of mucin. So if it's present and you get a lymphocytic infiltrate like this, you can say, well, maybe it's lupus or dermatomyositis, but it's not an unequivocal criterion for the diagnosis of either of these two diseases. So you may have it, you may not have it, but it just is a helpful finding if it's present. But if it's not helpful, it doesn't really mean anything. So again, interface dermatitis, lymphocytes, think DM, think of lupus, and realize that you really can't reliably tell them apart based purely on histology. You really need to get clinical information and serologic studies. Okay, now we're going to shift gears and talk about the sclerosing disorders of the skin. And we talk about sclerosis. Basically, there's two main things two elements of sclerosis, two criteria for the diagnosis of sclerosis histologically. We talk about an increase in homogenization of the collagen bundles and a decrease in the number of fibroblasts. So if you look here, there's almost no fibroblasts, and these collagen bundles are thickened and they're homogenized. They kind of blend one into another. It's almost like somebody just kind of took a blender and just took all these collagen bundles, just kind of blended them together. So when you see that, you should think that those are your criteria for sclerosis. Now we talk about epidermal reaction patterns, things like spongiosis, ballooning, and acantholysis, like we talked about before. When we talk about sclerosis in the dermis, that's a dermal reaction pattern. So it can be seen in any of the diseases where there is sclerosis clinically. Like for example, scleroderma, progressive systemic sclerosis, mixed connective tissue disease, morphia. If you take a biopsy of those, they all look the same. So once again, these are reaction patterns that cluster under the microscope. They all look the same and you can't really tell them apart. So you have to have clinical correlation. So just like with the lupus dermatomyositis, if you look at a biopsy like this, can I tell for sure whether it's morphia? Can I tell whether the person's got scleroderma and may have lung disease? The answer is no, you cannot. Now, a couple other things to notice. If you see the sweat glands sitting in what looks like a sea of thick sclerotic collagen, that's a very helpful diagnostic feature. That means that, normally your little eccrine glands live down in the subcutaneous fat. Well, the reason they look like they're sitting in the mid-reticular dermis here is that most of that fat has been replaced by this thick sclerotic collagen. So that's why it looks like it's sitting in the dermis. It really isn't. It's been replaced by the dermis, and the fat's been replaced by this thick collagen, and it looks like it's sitting in the middle of the normal dermis. Well, it's not. It's not normal at all. The other thing we talk about is the squared off biopsy appearance when you see it at low magnification. That's a clue that you're really dealing with sclerotic collagen versus just kind of a thick dermis like a lot of people have. If you get a biopsy from a lot of these men we see from the VA hospital from the back, all of their skin looks pretty thick there. But it's not sclerotic. They have plenty of fibroblasts in their dermis. So if it looks, and usually even though it's thick, it kind of contracts centrally. It kind of has got, elastic fibers in there, and it kind of pulls it in, and it kind of looks a little bit like a pyramid a little bit. It doesn't look like a square. So it looks a little bit different at low magnification. So if you see something like that, it favors the diagnosis of one of the sclerosing disorders. And then higher magnification, you see the features of sclerosis that we just talked about. Now, again, there are other diseases where you can get sclerotic collagen. Necrobiosis like Poitica, you can get sclerotic collagen there. You can see sclerotic collagen in the late stage forms of graft versus host. So these are, again, kind of reaction patterns, sclerodermoid PCT. So they can all look pretty similar. And you really need clinical correlation, or you can look for some ancillary features. Maybe, if you see granulomatous inflammation, obviously it would favor NLD. If you see the thick rims of collagen, type 4 collagen around the blood vessels, that might favor PCT, sclerodermoid PCT. But they can all look the same if you just look at the dermal collagen. One final thing about the sclerosing disorders that I'll mention, I think I mentioned this a couple of weeks ago, plasma cells follow sclerotic collagen. So whenever you get sclerotic collagen, looks like scleroderma, you'll often see plasma cells. You don't have to, but you almost always do. And over here, you've got a few. So again, no one's really looked at that, see why that happens. I personally think there may be some pathophysiologic significance of it, but it's something that you see in all of the sclerosing disorders. So And again, it depends on what stage they are. If there's really in a late stage where there's no inflammation, you may not see much of it like that last one. If it's an earlier stage like this one, you may actually still see some little lymphoplasmacytic aggregates, and they like to live at the junction between the sclerotic dermal collagen and the fat, if there's any fat left. So that's a good place to look. And if you see that, that's kind of a helpful clue that you're really dealing with one of these sclerosing processes, and not just some sclerosis that may be present coincidentally, or maybe you think it's just a thick dermis or a collagenoma, for example, which can kind of look a little bit like a sclerotic process. If you see aggregates of lymphoid cells and plasma cells, that helps in the diagnosis. So this case, again, another sclerosing process. The first one came from somebody that had systemic sclerosis. This comes from somebody that has morphia. And this really beautifully, even more than the last case, shows that homogenization of the collagen and the loss of the fibroblast here. But just, you can count the number of fibroblasts in this biopsy, maybe 10 or 15. And the collagen just looks like it's just kind of pink here. It's just smudged. And that's classic sclerotic collagen here. So that's, again, someone in this case, they had to happen to have morphia. One final thing that's not present on either of these two cases that I just showed, maybe I'll go back to the last one, there might be a little bit of it here. If you get early changes, the very first finding in the sclerotic diseases is not actually thickened sclerotic collagen, it's loss of mobility of the skin overlying the underlying structure. So first thing that patients will complain about when they have early morphia is to say, my hands feel swollen and puffy, and they're not as pliable as they used to be. I can't really move my skin over the underlying bones and tendons as well as I used to be able to. And that's because the first changes actually happen in the sept of the subcutaneous fat. And if you go down further, even between the bottom of the fat and the overlying fascia, there's early sclerotic collagen changes that occur right in those areas. And in the puffy stage of scleroderma or morphia, you'll see edema of these little tethered strands of thickened collagen bundles that go down all the way down to the fascia. And that's why when they say, well, I can't really open and close my hands as well, it's because of that early change of the edema of those areas in the subcutaneous fat and these little residual, these little zones of collagen. These are markedly thickened. Shouldn't really be that thick. Normally they're just almost invisible. When they start getting thicker, you can see them like this. That's really pathologic. And you can see a little bit of that edema right over here in this one. There's some mucin and edematous collagen there, edematous stroma. That's what you see in early edematous stage of morphia or scleroderma. Now this, another condition that's in the family of the sclerotic collagen fibroblastic disorders, is different. This is where you get actually fibrosis. Now the difference in fibrosis and sclerosis, in sclerosis you get a decrease in the number of fibroblasts. In fibrosis you get an increase in the number of fibroblasts. So notice here, lots of fibroblasts diffusely throughout the dermis here. So here we've got a fibrosing condition. And you've also got the squared off biopsy. So this isn't normal dermis. And this patient, if you were to see a patient that has this condition, their skin feels very thick and it looks kind of thickened and looks almost like an amoeboid kind of appearance to the little sort of rippled pattern that's on the surface. And this is not sclerosis again, it's fibrosis. This is nephrogenic systemic fibrosis. So here you've got an increase in the number of fibroblasts. And if you look here at these elastic fibers, and even here you can probably just barely see them, they've got this brownish gray discoloration, and that is due to the gadolinium that is precipitating on those elastic fibers. And then I'm not sure exactly what the pathophysiology is here as to why the gadolinium causes these fibroblasts to increase in number, but they do. And, perhaps this gadolinium comes in here and this precipitates on these elastic fibers, and the fibroblasts say, hey, what's going on here? And it somehow turns them on. They shouldn't be proliferating quite to the degree that they are. But you can see, even in this, it's about as high as we can get here. If you were to take this with oil immersion or even 60x power, you would see these fine stippled granules on those elastic fibers, and that's the gadolinium. And then in some cases, you'll actually see these little calcified so-called lollipop structures. I don't think we have any of those in here, but if you see those, they're actually coming in and they're reacting and forming a little structure, a calcific structure around those little zones of the gadolinium precipitate that occurs on these fibers. So you're not getting sclerosis here. You just get all of these fibroblasts with an increase in collagen, but not really sclerotic collagen. And we call this systemic because it involves many parts of the body. This disease, if you had a deep enough biopsy, goes all the way down into the fascia, to the muscle, to the bone. So it extends very, very deeply. And these gadolinium precipitate go right on these fibroblastic, these little collagen and elastic fibers that go all the way down into the muscle, the bone, and it really extends deeply. So again, not a good disease. We haven't seen as many of these diseases in the past as we used to see in the past because they're not really using the same kind of gadolinium as they were in the past. And these are really used for things like magnetic resonance imaging, patients that have kidney disease, they can't clear it out of their system. So that's why it's called nephrogenic. Occasionally we'll see it in patients that don't have kidney disease, but it's seen most commonly in that setting. And they usually have to get something like a magnetic resonance angiography. It really takes quite a bit of this gadolinium to really cause the problem. Okay, let's look at another one. And this one, another sclerosing disorder. So we're back now away from fibrosis back to sclerosis. And turn this over here. There we go. So there we go. We got another situation where the collagen is thickened in the dermis. So another morphia scleroderma-like process. And just to show that you really can't tell any of these apart from one another, this was actually a patient this time that had mixed connective tissue disease. So they all look the same. So you don't really need to try to distinguish them. You just need to recognize the sclerotic collagen. Sometimes in mixed connective tissue disease, you'll actually see features of lupus or some other kind of overlap connective tissue disorder in the same biopsy specimen. You don't have to, but if we just saw something like this, unfortunately, we wouldn't be able to really make a definitive diagnosis. We'd just be able to say dermal sclerosis consistent with mixed connective tissue disease if that was the clinical impression. Okay, let's move on to another condition, and this is one I think we saw a couple of weeks ago, and I'll just show you another example. But we saw this when we talked about the unknowns, where we showed kind of the potpourri. So notice at low magnification, we've got this so-called busy dermis pattern. We've got a lot of cells in the dermis, and notice, hopefully you'll remember from when we talked about this disease before, the cells are not arranged in a palisade. They're kind of going like north, south, east, and west. They're kind of splayed diffusely in an interstitial mostly pattern in the dermis. And this is what's very characteristic of Scleromix Edema that we talked about previously. And again, there are several different forms of Scleromix Edema. It can be associated with a paraproteinemia, so you always want to make sure your patient doesn't have an underlying monoclonal gammopathy if you get this diagnosis. And some cases are associated with a lot of mucin in the dermis, and some cases have very little mucin in the dermis. So here's one that doesn't have very much mucin in the dermis. You don't need it to make the diagnosis. You still suspect it on the basis of this pattern. So you don't really need special stains here. You can really look at this, and if you did a stain here, these cells will highlight with CD34. They'll also highlight with CD68, but you don't really need that. If you have a good clinical correlation that goes along with this pattern, these splayed cells diffusely in the dermis, you should be thinking of Scleromix Edema. And again, there's the papular mucinosis type, where you get these cells between them and collagen metals with a lot of mucin. There's some types where you get you get very few cells and you just see tons of mucin. It can look like almost like a cutaneous myxoma in some of these cases, but probably the ones that are papular mucinosis usually have more of these fibroblastic cells diffusely in the dermis. They demonstrate this characteristic splayed pattern that we see here. So that's Scleromix Edema. And the myxedema part comes from the cases where they actually get the mucin. Now this is still in the pattern of the sclerosing disorders. And we've got a punch biopsy and a low magnification. You can see that there's something going on here in the papillary dermis primarily. So we've got this markedly thickened cornified layer. And then we've got this very edematous papillary dermis with sclerosis of the papillary dermal collagen. And when we get this sclerotic change of the papillary dermis, it looks a little bit different than the sclerotic change we see in the reticular dermis. It gets kind of this almost delicate, gossamer, bubblegum pink sort of color to it, with this whitish discoloration that goes along with it, which is the edema of the papillary dermis. So you get this fine, so we get sclerosis of the papillary dermis, gives you this more fine pink color as opposed to that thick, homogenized collagen bundles. It's the type 1 and type 3 collagen bundles in the dermis that become homogenized. Here you're dealing with a different pattern. And this is classic for lichen sclerosis atrophigus. So when you see the sclerosis of the papillary dermis alone, we think lichen sclerosis. When it kind of gets down into the reticular dermis also, if we have reticular dermal sclerosis, then we refer to it as morphia with features of LSNA, where you kind of a combination of both. So LSNA, the pure form of LSNA, really should be confined to the papillary dermis. When it gets into the reticular dermis, well, then we refer to it as both a dermal sclerotic pattern with the LSNA pattern, rather than just calling it LSNA alone. And that's maybe of some importance. I mean, if you're going to treat the dermal, deeper dermal component of that, you're not going to be able to treat that with a topical steroid or something like that. This disease may be amenable to some of those things, at least to some degree, but once you get down into the dermis, it's harder to treat with a topical. And then one other thing about this, notice the cornified layering. So gosh, is this on the palm or sole? Well, no, there's a hair follicle right here. This is really markedly rubbed and excoriated. Well, it's not really excoriated, it's really more rubbed. And it's very common for LSNA to be prudic. And so patients get LSNA, often on the genitals, but it can occur in other extragenital locations. And because it's prudic, they rub it and they get this markedly thickened epidermis and overlying thickened cornified layer. Sometimes the epidermis, in later stages of LSNA, the epidermis can be very, very thin, but it can still have features of overlying lichen simplex chronicus on top of it, with maybe a very thick cornified layer, but not as thick as you would see here, maybe 3 or 4 sort of plates of thick cornified layer that's very thick and compact. That's another sign of rubbing, but you don't really usually get this markedly thickened cornified layer like you see here when it's on the genitalia. So this is LSNA. And again, just like we talked about before, whenever you get any sclerosis, you're going to see plasma cells associated with that. And indeed, there are quite a few plasma cells in this infiltrate. One other final thing about LSNA, because if you get that papillary dermal edema, you can actually get blisters that form. And over here, there probably is actually a little blister that's formed here. So it's not just clefting, you can actually get true bullous lichen sclerosis, and they're often hemorrhagic bulli with extravasated erythrocytes in the blister space. So LSNA, you can get vesicular change because of that papillary dermal edema that gets so, it's basically doesn't have the same kind of ability to hold the epidermis down to the dermis any longer. And sometimes there's another sclerotic condition where patients get radiation therapy and they get chronic radiation dermatitis, and this is an example of that. This is really, it's interesting here, we don't usually get biopsies of chronic radiodermatitis that extend deep. Most of the biopsies of chronic radiation dermatitis are usually taken by shave technique, where the clinician is kind of maybe crusted and oozing. They want to make sure that there's not a recurrence of a cancer or something like that. But in this case, we've got this sclerosis that extends deep down into the mid-reticular, lower reticular dermis. So this is probably radiation for somebody that may have undergone breast radiation or maybe radiation from some kind of a head neck cancer or something like that. Once again, you get the very thick homogenized collagen bundles. But one of the things that's helpful in radiation dermatitis, you see bizarre irregular fibroblasts in radiation dermatitis. So some of these irregular stellate fibroblasts, it can be atypical. You usually don't get mitotic figures, but they can be kind of bizarre in their morphology. When you get sclerotic collagen plus these bizarre fibroblasts with dilated blood vessels, you should be thinking about chronic radiation dermatitis. So it's yet another condition that gives you sclerosis, but instead of being associated with a total absence and decrease in the fibroblast, you actually get these bizarre stellate appearing fibroblasts associated with it in chronic radiation dermatitis. So here's another area of the upper part of the dermis that's involved. Again, you've got these homogenized collagen bundles here, and you've got these bizarre stellate fibroblasts. So that is chronic radiation dermatitis in that case. Okay, we're going to shift gears, and now we've got basically a deposit of something in the skin. So we're talking about disorders of collagen, elastic fibers. Well, fibroblasts are in the elastic, or they're in the collagen in the dermis, if you will. And sometimes they can produce a lot of mucin. So we talked about mucin a little bit earlier. But in this case, you've got this massive deposition of mucin that's present in the entire dermis, going pretty much from the top all the way to the bottom. And this actually was taken from an area where there's some dilated blood vessels superficially, maybe a little bit of stasis altered blood vessels up here. So this is an example of pre-tibial myxedema. And again, the myxedema just basically means a collection of mucin. So anytime you get massive quantities of mucin, it can look like this. So once again, you really need clinical correlation, because if this came from a shave biopsy, say of a skin-colored papule on somebody's back, rule out basal cell, it could be a cutaneous myxoma, which can look very much like this. But if it looks like kind of a squared off biopsy, it's taken from near the lower leg, and it's got all this mucin in it, well, that's pretty classic for pre-tibial myxedema. So this is, again, just a collection of abundant mucin. It's hyaluronic acid. Again, it's due to thyroid abnormalities. Probably the long-acting thyroid stimulator comes in and causes these fibroblasts and mast cells to produce all this massive amount of mucin. It's not circulating in the body and depositing here. It's being produced here. So it's local production of mucin, but it's being stimulated by a host response, probably the abnormality associated with Graves' disease and the long-acting thyroid stimulator antibody that gets produced here. So that's pre-tibial myxedema. Here's another disorder of collagen and elastic tissue, and it's a shave biopsy of this big, thick nodular lesion. And you can see it's got these markedly thickened, ropey collagen bundles like you see here. And when we see those kind of collagen bundles that are 10 times thicker than normal, associated with an increase in the fibroblast, that's an example of keloidal collagen. And of course, keloidal collagen is most commonly seen with a keloid. And indeed, that's what this is. This is a keloid. And keloids are, again, associated with an increase in fibroblast. And they actually, the fibroblasts produce this bizarre, irregular, thick collagen bundles. When it starts off, the collagen bundles don't have that keloid morphology. If it's just a hypertrophic scar, it kind of looks like this. And then over the course of time, they get more thickened and ropey and then begin to look like these kind of pink, thick bundles that we see up in here. So when we see just this material, we can probably call that a hypertrophic scar. If we start seeing these actual keloidal collagen bundles that get formed, well, then we go ahead and call it a keloid. So these, as you know, these conditions are very recurrent. They're refractory. Probably one of the best ways to treat these is with radiation therapy. Basically, you shave them off in one technique or another, and then follow it up with radiation therapy. Generally done almost right away. You want to kind of do it that same day. The first treatment really needs to be within a few hours after you kind of cut the keloid off. Now this, another disease, so punch biopsy, almost nothing that we see from an inflammatory perspective here. As we go to higher magnification, we've got this bizarre appearance in the dermis here. And if we go to highest magnification, we see what looks like steel wool. And for those of you who don't know what steel wool is, it is still used in industry and things like that. A lot of guys, when they're polishing silver or metal or something like that, they take steel wool and rub over it. But in the old days, before we had dishwashers, like my grandmother, she would actually clean her pots and pans, taking steel wool and use it and scrape off all the food residuum there, and then use soap and water and rub it off. And that's how they clean their pots and pans. And so if you look at steel wool, it looks like these little fine granular structures of the elastic fibers like you see here. And this is classic pathognomonic for Pseudoxanthoma elasticum, or a Pseudoxanthoma elasticum-like reaction, degeneration of the elastic fibers where there's this precipitation of calcium on them, and then it has this morphology. And you can see that reaction pattern. Again, we're talking about dermal reaction patterns today in a number of different conditions. You can see it in necrobiosis lipoitica sometimes. You can see it rarely in morphia. You can see it in women that have the so-called PXE-like scarred-like changes when they get pregnant a lot of times. They get these scar-like lesions in the umbilicus area, and then you biopsy those and it shows this PXE-like change. And then the other case where you see it is due to certain drugs. Penicillamine classically causes a PXE-like reaction. And if you look at the individual elastic fibers there, they have this so-called bramble bush-like morphology. They have these little tiny spikes that come off the elastic fibers at 90 degrees with these little sort of dots around them. And if you do an elastic tissue stain, you can see that quite nicely. But the other stain you can do here is von Cass's stain to stain the calcium, and it will light up the little calcium granules on these elastic fibers quite nicely. So this is PXE pseudoxanthoma elasticum. It's an autosomal dominant disorder. The last time I checked, if you want to double check me and make sure it's not autosomal recessive, and I'm pretty sure it's autosomal dominant. And they get the areas of these atrophic scar-like areas on their skin, and you biopsy and it looks like this. And they can also affect other parts of the elastic fiber in the body. They can get, their aorta can be involved, their heart can be involved, eye can be involved. So anywhere there's elastic fibers, elastic tissue in the body, they can develop this degeneration due to the calcification of the elastic fibers. So that's PXE. So make sure you understand that dermal reaction pattern. Okay. We're going to look at this lesion here. And this is one of the disorders that we refer to as the perforating disorders. So unfortunately, we have a shave biopsy. We really would like to have a punch biopsy of this condition. But you can see that there's epidermal hyperplasia. And within the epidermis are these little small areas where there are neutrophils. And also there's this pink refractile degenerated collagen and elastic fibers that are being transepidermally eliminated out of these little channels here. So this is a transepidermal elimination of altered elastic fibers here primarily. You can also get transepidermal elimination of collagen bundles as well in patients that have so-called reactive perforating collagenosis. Now, most of these conditions like that, perforating folliculitis, Curley's disease, is really secondary to lichen simplex chronicus. If a patient that has one of these diseases gets in a car wreck and they basically go into a coma and you put them in the ICU, their disease goes away because they can't touch it, because they have to basically rub and scratch these to get the degeneration of the elastic fibers and collagen in the dermis, and then gets transepidermally eliminated. If you don't have that stimulus, it goes away. Now, this disease, elastosis perforans collagenosa, it is associated with other conditions like Down syndrome and things of that nature, Ehlers-Danlos. So in those situations, it probably is due to a biochemical alteration of the collagen and the elastic fibers that causes it to be recognized as foreign, and then it actually gets transepidermally eliminated. But in things like perforating folliculitis, that's generally due to pruritus, and then the person causes the damage that then gets secondarily transepidermally eliminated. Possibly in patients that have renal disease, if there is renal pruritogens that may get deposited on collagen bundles and elastic fibers, they may become immunogenic that way. But you pretty much need trauma in most of these diseases or it goes away. So this is elastosis perforans serpiginosa in this case. And, perhaps this was a real situation where the patient may have had Down syndrome or something like that, and these elastic fibers here were biochemically altered in vivo, and then they get transepidermally eliminated in this one specific disease. But you can see there's even some epidermal hyperplasia and rubbing here, so there's probably a component of that even in this disorder. Okay, the last one we're going to look at this morning is a disease that is probably not a disease sui generis. It probably goes along with morphia or scleroderma, and it's called atrophoderma of Pacini and Perini. And the way I like to think of this is probably a patient that's got long-standing morphia or scleroderma, And then if you leave those those conditions alone long enough, eventually they go from that thick sclerotic collagen to more of an atrophic condition. And if you see these patients clinically, you'll feel their skin and you'll actually feel kind of a drop off. It's almost like a shelf. And basically what happens there is the sclerotic collagen gradually gets kind of reabsorbed and degenerated, and they're left with atrophy where they once had the thick sclerotic collagen. You can still see there's some suggestion of some of that here. You know, this collagen is still somewhat thickened. It's not quite as sclerotic as we saw in the earlier lesions that we looked at. So this is probably where the sclerosis is gradually getting remodeled and it's going away, but it never really goes back to perfectly normal skin, and it's got some atrophy there. So it's basically just a manifestation of a late stage burned out form of morphia or one of the sclerodermas when you're looking at atrophoderma more out of the Pacini and Perini. So no disrespect to Pacini and Perini, but sadly enough, your disease is probably just a late stage burned out form of morphia. So that's it for the disorders of elastic and collagen and the one palisaded granuloma we looked at today. So basically, just remember connective tissue diseases. Basically, it's not such a good name because it encompasses the so-called collagen vascular diseases, as well, lupus, dermatomyositis, scleroderma, but it also encompasses some of these other diseases where you get alteration of collagen and elastic fibers that can give you changes as well. So I hope you enjoyed the session. We will do another one of these next week, and please feel free to contact me with any questions or comments, and we'll see you next week.